Good afternoon, everyone, and I'm Dr. Bharati MEGUR. This instruction course is on basics of anterior vitrectomy for cataract surgeon. There is a keynote address by Dr. Niaz from Bangladesh. So after that, our IC will begin. Okay. Sir, are you ready?
Yes, yes.
So I have a team of excellent speakers who will be speaking, and this is a video-based course. So at the end of the session, you can clarify your doubts. Each of the speakers will finish their talk, and towards the end, we'll have some discussion.
Thank you very much. Good afternoon. Greetings from Bangladesh. I'm grateful to the organizers, especially Parthu বিশ্বাস, for giving me this opportunity in this session. My topic is slightly different, but there are certain similarities with what's going to be in the session. I'm going to talk about cataract surgery in special situations, that is phaco in vitrectomized eyes. Now, after pars plana vitrectomy, one can develop cataract, and it is very common, especially if there has been a tamponade in the eye. People do develop cataract, and the vitrectomized patients account for some of the most challenging cataract surgery cases. Now, to start off with, I'd like to just reiterate that phaco versus SICS. In these eyes where vitrectomy has been done, there's no vitreous in the posterior chamber, it's only fluid. It's the aqueous, actually, which fills up the posterior chamber. And if someone wants to do an SICS, it is often that when delivering the nucleus, you have to apply a little bit of pressure in the eye. And this fluid from the back can come out, and the eye can become hypotenuse. If an eye becomes hypotenuse in these cases, the surgery becomes very, very difficult. So a closed chamber surgery is our goal. That's why I would always prefer to do a phaco, never an SICS, to do cataract in a vitrectomized eye. Now, especially after gas or oil tamponade, the kinds of cataracts that we normally see, they're usually dense nuclear sclerotic cataract. And if during surgery we have touched the posterior capsule or injured it, if there has been no rent, still you can develop a posterior subcapsular cataract, or sometimes a posterior plaque can form. I'll show you a video of it. And if there has been a rent in the posterior capsule, then quickly the cataract, the fluid imbibes into the lens, and the lens can become absolutely white, and then there is a PC rent, and during surgery you can have a fall of the nucleus in the posterior chamber. Therefore, the challenges we face are, like I've said, dense nuclear cataract, posterior capsular injury. Apart from that, you can have a fluctuating anterior chamber. So in those cases where especially myopes, high myopes who has had vitrectomy done, the tension, intraocular pressure can fluctuate during surgery as the fluid comes up and down. Therefore, it can be very difficult. And these cases, the pupil can become myotic. There can be zonular dialysis. And of course, with the PC rent, you can have a dropped nucleus. Those are the challenges you face. Now, just to show you a small video, you see, this is a vitrectomized eye. And if you want to stain the nucleus, if you put in a stain, trypan blue, if you wait for a little while, what can happen is this blue can seep into the posterior chamber. And then you have just lost your red reflex. Once you wash the trypan out of the anterior chamber, you just have lost the red reflex. And surgery is so difficult. Therefore, if you want to use trypan blue in a vitrectomized eye, you should put the dye in and very quickly remove it. If you leave it for a little while, it might just go in the back, and then once you've lost the red reflex, to get it back, you have to wash out the posterior chamber, or else you can't do it. So you just remember that putting a dye in, you have to wash it out very quickly. Now, often we do surgery where there is silicone oil. Sometimes the silicone oil has emulsified. It's very easy, just from the paracentesis, you can wash it out. But at times, what happens is, if there is zonular laxity, silicone oil can ooze into the anterior chamber. In this case, you see, as soon as hydro was attempted, silicone started coming into the anterior chamber. Now, the surgery gets very difficult. Phaco is attempted in every step. If after every few seconds, silicone is oozing out into the anterior chamber, and life is so difficult. We put in an cannula in the pars plana because the eye was getting soft as so much silicone coming out. But then the pupil started going down, and this surgery became very difficult. This can often happen when there is silicone oil in the eye, and the only way is someone has to wash out the silicone, remove the silicone, and then proceed with the surgery. So this is a really difficult complication that you can face in vitrectomized eye with silicone in the posterior chamber. Now, the other problem is that, you can have fluctuating anterior chamber. You see, with the finger, I measured the intraocular pressure. If the pressure is low, then we should all learn how to put in a cannula. Nowadays, everybody can put in a cannula. And with that, you can maintain the intraocular pressure. Like if the intraocular pressure is low, you just put in a few drops of BSS and the eye hardens up. If it is the other way around, you can let out a few drops. Like in this case, now the AC has shallowed and I've just taken out the cannula, let out a few drops, and you'll see that the AC will deepen with, now you can proceed with the surgery. So the intraocular pressure is in our control once we have put in a cannula. So in a vitrectomized eye, putting in a cannula sometimes makes life easy because we have in our hands, we can control the intraocular pressure, and whatever pressure, however pressure we want, however depth of the AC we want, we can do it ourselves. So that's a trick. Now, posterior capsular plaque. You'll see, well, the plaques can be sometimes very hard, sometimes not so hard. But I always try to remove the plaque from the anterior side. I usually try to peel it off. And if it's stuck very hard with the posterior capsule, you cannot peel it off and you can't get a tear. But like in this case, most of it was out, but there was a tag. I tried removing it with the scissor, but I made a small nick. And as soon as I did that, it was a small nick. I immediately put in the IOL, myos the pupil. Then with the cutter, I removed the plaque with the vitreous cutter because the plaque was so hard. Doing a YAG would have been very difficult. In this case, a lot of energy would have been done. I could have easily made pits in the lens. But at times the plaque is not as adherent, and in those cases you can remove it. That is why I always attempt to find out how much adhesion the plaque has to the posterior capsule. In this particular case, with gentle nudging with the forceps after the phaco, I'm trying to see whether it will come out or not. And the lucky days, some days are lucky, some days are not. This was a lucky day and it just came out very nicely. Posterior capsule was intact and IOL could have been implanted. Now, the worst thing is a pre-existing PC rent. In this particular case, the cataract was dense. We couldn't really determine whether PC rent was there. As soon as we started surgery, we did a little bit of phaco and the nucleus dropped down because there was an existing PC rent. We started off with topical, so instantly we gave some subconjunctival xylocaine, and that is enough actually. You don't have to give a full block. You can do a pars plana vitrectomy with a subconj injection. So we converted it into a pars plana vitrectomy situation and we put in a fragmatome. And as it was a vitrectomized eye, it took just a few minutes to remove the nucleus from the eye. So friends, the whole thing is that all our anterior segment surgeons must be familiar with these small problems that can happen if you want to do a cataract in a vitrectomized eyes. And all of us, we must learn how to put in a cannula. Nowadays, there are a lot of workshops going on here and there. Putting in a cannula is very important, I think, because that in many situations you need to go in the back. If there's a PC rent, you can do a vitrectomy from the posterior part. So all of us, we should learn how to put in a cannula and use the vitrectomy cutter with our phaco machines. Thank you very much for hearing me out. Thank you.
Thank you, Dr. Naz. I think thank you for sharing your experience and hope you're having a wonderful stay in India.
Yes.
Thank you for coming.
It was a nice conference. Very nice conference.
Hello? Yeah. Without any delay, we'll start the IC now. Since Dr. H.M. Ravindranath has not joined us, I'll be speaking on his topic. His topic is anterior vitrectomy for cataract surgeons, the vitrectors and sterilization. So in the modern day cataract surgery, whether you're a manual small incision cataract surgeon or a phaco surgeon, immaterial, you need to have a good vitrectomy machine with you, because irrespective, all of us, whether we are a novice surgeon or an experienced surgeon, we would have a PC tear, we would have complications with vitreous, and we need to manage efficiently so that well managed vitreous disturbance or PC tear, the results are indistinguishable from the routine cataract surgery. There is no financial interest in any of the equipments or the devices which are being mentioned in this topic. Lot of equipments names are taken in this presentation, so there is no financial interest. What are the options do we have? We have inbuilt vitrectomy machine in phaco. So phaco machines come with inbuilt vitrectomy setup. Then we have standalone anterior vitrectomy system, which is very beneficial for manual small incision cataract surgeons. So a separate vitrectomy setup or a standalone vitrectomy system can also be there, or a full-fledged vitrectomy system with both anterior and posterior vitrectomy incorporated. So what are the variables that come into picture whenever you are thinking about vitrectomy? Type of the pump, whether it is peristaltic or venturi, type of the cutter, whether it is pneumatic or electrical, and the number of cutting rate which is available starts from 700, ranges up to 5000 cut rates per minute. So how did the vitrectomy journey start? It started long back with ICCE, where intracapsular cataract surgery was done and the anterior hyaloid was disturbed. All surgeons tried not to disturb the anterior hyaloid, but eventually, if it did happen, they used to do a sponge vitrectomy, that is sponge and scissors. But later on, Macamber came up with the concept of automated vitrectomy. Now we have a highly evolved closed chamber technique of anterior vitrectomy as well as a posterior vitrectomy. So the pneumatic cutters, which are air-driven, are the conventionally used popular device which we use in our anterior segment surgery. It has been the gold standard. There are electrical cutters in machines like Legion. So using electrical energy to drive the motor, not so efficient because the opening of the cutter is 50% closed because of the duty cycle. Pneumatic cutters also have their drawbacks. What are the type of mechanism of cutting of the vitreous happening? You have a guillotine-like cutting, rotatory cutting, that inner tube rotates within the outer tube to cut the vitreous, and the oscillatory cutters, which are similar to rotatory type, but the rotation is not 360 degrees but 180 degrees. So coming to the different type of machines which you are all familiar with, from now the list of machines begin. Here we have a Centurion vision system. The size is 23 gauge, cutter is dual pneumatic, and the cutting motion is oscillating. So next we have the Legion phaco system, which has a 23G cutter. It is electric. The cutting motion is oscillating, and here it is disposable. The Earthly Cataracts 3, which is also a phaco machine, comes up with a pneumatic cutter which is disposable and with inbuilt compressor. Then we have our own Chakshu machine, which is pneumatically driven guillotine type with an internal compressor with up to maximum of 750 cuts per minute. It is controlled in linear panel and single cut mode. Then we have this J&J Signature Pro and Intuitive with a pneumatic cutter of 2500 cutting rates per minute. So this is another type of electric cutter which is available with the Sovereign Compact, which is 20G in size. The cut rates are 600 CPM. So coming to the Reticare standalone anterior vitrectomy units, which are most manual small incision cataract surgeons possess. This offers a rate of 900 maximum CPM. It has to have an external compressor. But the advantage is you can use autoclavable vitrectors with this machine. Autoclavable vitrectors are available from Mid Labs. Coming to the final part of this presentation, here we have a cleaning process of the vitrector going on. Disconnect the tubes once the vitrector has been used. the instrument is brought to the cleaning area, or this procedure can be done intraoperatively or in the operating area itself. Using a 50 cc syringe, 3 flushes of distilled water is done. Once 3 flushing is done, then a 2 flush of air is also done. If you have an autoclavable cutter, then this is sent for autoclaving. Both the tubings and the cutter are sent. If you don't have an autoclavable cutter, this is sent for a ETO sterilization. This is how the packing is done for the sterilization process. The first pouch is sealed with the cutter and the tubings. So the airtight sealing process has to be foolproof, so double sealing is done. And this pouch goes into a second larger pouch, and watertight foolproof sealing is done again, so that the sterilization is adequately done. This is then placed in the ETO chamber for the sterilization to occur. So it undergoes the ETO cycle, and once the ETO cycle is complete, then the cutter can be used after the standing time is completed. So this is about the presentation regarding the vitrector and the sterilization. The next presentation is by Dr. Mallikarjun. So,
Dr. Mallikarjun Heralgi, he's from Sankarai Hospital, Shivamogga. He'll be speaking on setting up and using a standalone vitrectomy machine. Now, how do you set up and use this? So he's going to simplify for us, and he's going to show us some video on that. Over to you, sir.
Thank you, Dr. Megur, and thank you, Dr. Bharathi, for including me in this interesting IC. And mainly my topic is on standalone anterior vitrectomy, how to use it, and what are the troubleshooting, and also sterilization. I have added, there is a little bit overlap of the previous presentation also.
So can we have the audio ready for you?
Yeah. Vitreous cutters are based on the Galitron principle.
This is not changed.
When the vitreous gets engaged to the cutter, it gets into small pieces and makes aspiration easy. When you see inside, there is a spring which will be moved with the help of air pulse, and the blade will move to and fro. There are modifications of these cutters also, where there is no spring, but there is the air pulse for the forward movement and backward movement of the cutter. This is the front view of the vitrectomy machine. It has a 2 digital display for cutting and aspiration, one knob for vitrectomy probe, and other knob is for adjustment of the vacuum and the electrical switch. The cost is much lesser than auto refractor. One can easily afford to buy this machine. This is the back side of the vitrector, air inlet, vacuum for foot pedal, and electrical switch wire. And the air comes from the central compressed air outlet in our hospital, and also these machines will come with the small tiny compressors. This is a small bottle which helps to create vacuum by Venturi pump system. This is the cutter with 2 tubes. One is in blue color, other one is in white color. The blue is for cutter and white one is for vacuum. So one should not confuse when you are setting it. The vacuum outlet is connected to the vacuum bottle with a tube. The other end is connected to the Vitrector vacuum tube. The cutter tube is connected to the Vitrector console, blue to blue. The right side of the foot switch is for cutting and aspiration, left side is for only aspiration. Now it is connected to the electricity and switched on, and front panel switch is also on. Now we can adjust the cutting rate. It can go up to 900 cut rates. And we also can adjust the vacuum by pressing on the foot pedal and rotating the knob. In this machine we can set up to 650 vacuum. To check the cutter whether it is working or not, put it into a bowl containing BSS. First aspiration, press on the push pedal. You can see the BSS getting aspirated and it is getting collected into the vacuum bottle. To check the cutter, you have to see the tip of the cutter. It will be oscillating to and fro. That means it is cutting correctly. Most common one is when you are priming, the cutter is oscillating, but when you are actually cutting the vitreous, it is not cutting. Probably cutter may be old and it has lost its efficiency, or the cutter sharpness is reduced. The solution is you have to change the cutter. If the probe is connected other way, air bubble will come out. Now everything has been connected, the vacuum is not generating. So you have to recheck again. Probably the tip of the vacuum bottle is loosely capped. So you have to tighten the cap and check again. Now the vacuum is slowly building up. So if you connect the vitrectomy tubes loosely, when you press on the push pedal, it will suddenly. Sometimes the vacuum won't generate. When you look at the vitrector, the tubings looks fixed, but the tip may be flared up. That time, the small jugaad, what you can do is cut the tip with scissor and refix it. So now it will be snugly fixed and it would generate normal vacuum. Now, how to maintain the anterior vitrectomy machine after the usage? Every time after completion of the anterior vitrectomy, you reconnect the machine and take a bowl and put a BSS in there and put a probe inside and check cutting as well as aspiration. So that would aspirate the fluid and also releases any clog with the vitreous, viscoelastic or any cortical material. And also you should see the free flow of the BSS in the tubings. That would ensure that any clogging has been cleared. Flush the cutter with BSS just to doubly ensure that there is no clogging in the cutter. The tubing is dried with the help of air compressor. Before packing, the tubing should be folded in a rounded fashion and apply a bandage. Then it is placed in a pouch. The sterilization is usually done by ETO because you have applied the sticker. When you are opening it, the tubings won't fall in the unsterile area, and also it will ensure not to damage the cutter. Thank you.
How much time will it take to set up this machine?
No, actually, it takes around 10 minutes. Actually, not in 10 minutes, but once you start using it, but within 4 or 5 minutes, you can.
I think once you train your staff very well, I think you should not take more than 3-4 minutes to set it up, I guess.
And also, you should not be kept for long for ideal.
Okay.
So every time, every week, you have to check the cutters.
A dry run. You should always have a dry run. Yes. I think timetable for dry run. Yes. If it is going to take time, I think you should always keep it ready and connect it, and then do surgeries for the list. Yes. That also. Thank you, sir. Yes.
And I think that was a good idea that you placed a sticker inside the pouch so that doesn't fall.
Yeah, wrapping with a sticker.
This we found out after our experience. What happens? The PC and vitreous loss is a panic situation. So we ask for anti-vitrectomy. They usually they suddenly open it. Sometimes it will fall on the
unsterile area,
and sometimes it will fall on the unsterile. Then what you make is you put on sticker there. You fold it roundly and put a sticker. So even if they remove it faster, it will fall on the.
I think these standalone vitrectomy cutters, there are two types: inbuilt compressor, and what you showed was additional compressor, which is around.
Yeah.
So it might be a good idea if you have multiple OTs, because like I think hospital is big one. So if you have an inbuilt compressor, you can move it around very quickly without.
Can you name one inbuilt compressor standalone vitrectomy?
Yeah.
One company name which has got an inbuilt compressor.
Oscar Vision has a inbuilt compressor.
Okay, fine. Thank
Costa Vision, is it?
Oscar.
Oscar Vision.
Okay, now I think Dr. Bharati Megur will be speaking on principles of anterior vitrectomy, the basics.
So I'll be speaking on whys and hows of anterior vitrectomy. So as we all know, we do have sometimes PC tears, vitreous disturbance. How to go about it? What are the guiding principles for managing a vitreous disturbance? These are the answers every cataract surgeon should know. So we have a vitreous disturbance here, and vitrectomy is going on, and it is mandatory that we use triamcinolone. So what is the goal of anterior vitrectomy? Is it simply to remove the prolapsed vitreous? No. It is, in addition to cut and removing the vitreous, we have an additional responsibility not to cause any traction to the vitreous base. As we all know, vitreous has strong attachments to the optic disc and the base, wherein you can induce giant retinal tears and retinal detachments. And in some cases, if the vitreous is not managed well, long-standing cystoid macular edema can as well occur. So we need to manage vitreous very efficiently. So to prevent intraoperative vitreoretinal traction is an additional responsibility. Do we need to be very skillful to manage vitreous prolapse and vitreous disturbance? It is no. The answer is no. Any surgeon, any cataract surgeon can manage vitreous disturbance. The right kind of equipment, the knowledge about how to do vitrectomy is the basic need of the hour. What are the goals is cut and aspirate the prolapsed vitreous, and also to avoid any collateral damage to the iris, the capsular bag, the rhexis margin, and including the retina. So the basic components are a cutter. The main component is a cutter. This is a slow cutting motion at 500 cut rates. When you increase the cutting to 1000, you are unable to see the blade which is cutting there. This is just a sample demonstration. Do we need irrigation? Yes. Why do we need irrigation? Irrigation maintains the anterior chamber and also it prevents any endothelial damage. But we need to be careful what is the kind of irrigation we need. It should be titrated such that it does not disturb the anterior chamber. It ensures that the structures are maintained in the normal anatomical way. It is always mandatory to have a closed chamber technique, because it is, if you have leaky wounds, vitreous keeps on prolapsing and there is no end point to the vitrectomy which you are doing. So we need to have a closed chamber technique, but it is easy in phacoemulsification because it is a very small incision, whereas in manual small incision surgery we need to suture the main wound if it is not watertight. Why do we make typically 2 ports? Because one will include the infusion in one port and the other will be for the cutting. Bimanual vitrectomy cutting is the ideal way to manage the vitreous. As you can see here, there are no leaky incisions here, and the vitrectomy is being done. Suture can be put or not, it's an option depending upon the water tightness. Sometimes we go through the main wound to do the vitrectomy. What are the parameters to set on the machine? Always the first thing, whenever you suspect the PC disturbance or a PC tear, decrease the bottle height. So once the bottle height is decreased, the infusion pressure or the infusion that is happening in the anterior chamber decreases, and sudden gush of contents from the anterior chamber towards the vitreous does not happen. So here the infusion is introduced in this video, and suddenly you see the PC tear increasing in size. So this has to be avoided. Whenever the instrument is there in the anterior chamber and you are bringing out your instruments out, always a OVD dispersive, preferably a dispersive OVD has to be injected and the instruments have to be brought out. So do watch for the bottle height. So whenever the anterior vitrectomy is complete, you can titrate your settings and increase or decrease the bottle height. Typically use the maximum cutting rate that is available with the machine. Whichever machine you are using, the maximum cutting rate has to be used to avail the efficiency of the cutting. Always the vitreous has to be cut. It is kind of a jelly structure, so the cutting has to be so efficient. The vitreous has to be cut, then the aspiration occurs. So here the lowest possible aspiration flow rate is used. As you can see, that is the white coated vitreous, triamcinolone coated vitreous which has come up to the cutting port. So what are the typical foot positions? You have the foot pedal in some of the machines. Any machine will have irrigation in the beginning, then the cutting occurs, then the aspiration occurs. This is the typical way a foot pedal is set in the vitrectomy cutting mode. Certain machines have cutting first and aspiration and then aspiration. So especially I think machines like Infinity and Centurion have this cut IA mode. So this will help in aspirating the epinucleus and cortex. Also you get to do iridectomy with that. Typically, how do you hold the irrigation? The irrigation port should be held in such a manner that you are not going to irrigate the vitreous further and push the pressure inside the vitreous cavity much more. So the irrigation should be directed away from the site of the PC tear. The vitrector should be held in such a manner that you are going to clear the vitreous adequately enough, not bring down or bring out the entire vitreous out of the vitreous cavity. Whatever the PC tear disturbance has occurred at the posterior capsule should be cleared enough so that the IOL implantation can be easily done. So just hold the cutter near the PC tear or slightly deep enough to clear the vitreous from the area of the PC rupture. This also prevents traction to the vitreous base because now you're not now pulling the vitreous towards the limbal entry. As I mentioned earlier, triamcinolone is a great tool for identifying the vitreous because vitreous is an invisible structure. Sometimes it becomes very difficult to identify the presence of vitreous in the presence of dispersive OVD. Triamcinolone is a great tool to identify the vitreous, and then we use a dilution of 1:4. So 1:4 dilution, these are the triamcinolone particles which are seen inside the anterior chamber. Once the vitreous is identified, it becomes extremely easy for the operating surgeon to clear the vitreous from the anterior chamber. But we need to be watchful for the the post-operative follow-up for the intraocular pressure fluctuations which can occur with the use of triamcinolone. We see that sometimes the triamcinolone gets into the vitreous cavity, but that will resolve over a period of time. What is the end point of vitrectomy? Once the vitreous is cleared from the anterior chamber, sometimes you see the fluttering of the posterior capsular tear edges, which were held by the vitreous initially. Now, once the vitreous is free from those edges, the fluttering starts to occur. This is almost that you have reached the end point of vitrectomy. Other than that, micro shallowing of the anterior chamber, then small amount of Descemet folds which appear, corneal folds which appear, these are also the signs that you have reached the end point. Some amount of hypotonia also sets in. This is identified when you insert the instruments, the dimpling of the cornea can occur. This also identifies that you have reached the end point of vitrectomy. So to conclude, all of us as cataract surgeons should be well versed with these necessary skills for anterior vitrectomy, and invariably the results are so indistinguishable from the routine cataract surgery that it is always very quite satisfying at the end of doing the anterior vitrectomy, and this will give you a stress-free result. So I encourage all of you to adopt anterior vitrectomy whenever possible for your routine cataract surgery cases when you have complications. Thank you.
I think this is a most beautiful video to learn anti-vitrectomy and should be seen by all anterior surgeons. One point you have shown it already in the video, but just to highlight, many times we get these anti-vitrectomy cutters with needles for the irrigation, and many times I have seen surgeons using those needles rather than what you are using was the irrigation cannula of the bimanual IA. So in that the irrigation is sideways. So usually it doesn't go directly into the vitreous. So don't use those needles which come with the cutters. Use a irrigation cannula of a bimanual, so you don't hydrate the vitreous that way. I think you have already shown that, but I think
if you have a needle, the jet of fluid is going anteriorly and might hydrate the vitreous. But if you have a bimanual irrigation cannula, it goes sideways.
We all know.
Okay, once the basic principles of anti-vitrectomy are understood, now assuming that once we have had a posterior tear now, and now we are in the process of doing vitrectomy. So one of our goals, apart from all what was mentioned by Dr. Bharati, is to prevent the enlargement of the posterior tear while doing the anti-vitrectomy itself, so that it gives an opportunity to place the original lens into the bag. Now let's try to understand some basic principles by which we can achieve this.
Dr. Vasavda has beautifully demonstrated that pass-plan approach for the anti-vitrectomy greatly reduces the incidence of extension of PC tears. Can we achieve the same goal of prevention of enlargement of the PC tear but through the anterior limbal root itself by doing something differently. Now, how can we achieve this? Number one would be to maintain the antechamber equilibrium at every step. We already know this. We put in dispersive OVD before removing the irrigation to prevent its shallowing. Number two would be to decrease the infusion pressure as we begin the antivitrectomy. We need to reduce the bottle height since the chamber is already filled with dispersive OVD. Any sudden raise in the infusion pressure inside the eye with an open posterior capsule is one of the most common reasons why the posterior capsule tear enlarges during antivitrectomy. Number three, segment the prolapsed vitreous into two parts. One segment which is below the level of the posterior capsule, and the second one would be above it. This is achieved by placing the cutter behind the level of the posterior capsule tear and then initiate cutting with a very high cut rate and low vacuum and low flow rate, with the port held sideways and then posteriorly so that the vitreous behind the PC is segmented away from the anteriorly prolapsed part, and later on the prolapsed anterior part is taken care by rotating the tip anteriorly. By segmenting the vitreous in two different parts, we'll be able to prevent the vitreous from behind the posterior capsule tear migrating anteriorly while removing the anteriorly prolapsed vitreous. Let us examine these points in the following few cases. If we have a posterior capsule tear with a vitreous prolapse, dispersive OVD is placed, triamcinolone acetate placed, time to perform the antivitrectomy. The first thing to do is to reduce the bottle height. The bottle height is decreased to the minimum. It is kept at 28 centimeters. The other parameters are standard, that is high cut rate, which is the highest possible with that machine, with the low flow rate and vacuum. Now, since the chamber is already filled with OVD, this low bottle height can still work as the vitrectomy is begun. Vitrector is positioned just below the level of the posterior capsule tear, and with the port facing sidewards first, followed by posteriorly, the vitreous is segmented from the anteriorly prolapsed vitreous. Then the port is turned anteriorly and the prolapsed vitreous is then taken care of. The bottle height is progressively increased as the chamber is emptied of the OVD and the vitreous, so that the chamber equilibrium is not compromised. Once the vitreous is cleared off, the cortex is aspirated, and at this stage the PC tear has not enlarged. The originally planned intraocular lens is placed into the bag. Our goal of preventing the posterior capsule tear enlargement could be achieved. Case number 2. The posterior capsule is broken. We can also see an inner ring, and this is the ruptured anterior hyaloid. As the OVD is being placed into the antechamber, we can see the prolapsed vitreous finding its way towards the side port. The edges of the capsular tear are irregular and are at risk of running away during vitrectomy, thus increasing the chances of posterior capsular tear enlargement. Now let's have a step-by-step approach of managing this case. The prolapsed vitreous near the wound is first cut with the vitrector. Then the cutter is introduced into the antechamber, which is currently maintained by OVD and the prolapsed vitreous.
At this point, you can note the chamber is filled with OVD. I'm not introducing my irrigation cannula still. The first thing which goes in is the cutter itself. It is taken care of all the vitreous which is near the wound. The irrigation still has not gone in.
First thing to do is to decrease the infusion pressure before beginning vitrectomy. The infusion is started with a bottle height of just 20 centimeters. The vitrector is placed just below the posterior capsular tear, and the port facing sideways first and then posteriorly. The cutting is begun, which takes care of the vitreous around and behind the PC tear. At the same time, the vitreous is segmented and the prolapsed vitreous in the antechamber does not have any communication with the vitreous behind the PC. The bottle height is gradually increased as and when we notice the fluttering of the antechamber, suggesting any minor compromise in its stability. The prolapsed vitreous is then taken care of. The PC tear continues to be of the same size. Before implanting the IOL, the tear is converted into a posterior capsular rhexis. The planned single-piece lens could be placed into the bag. So to conclude, we can reduce the incidence of PC tear enlargement during translimbal antivitrectomy by following the 3-point approach. Number 1, maintain the chamber equilibrium at every step. Number 2 would be decrease the infusion pressure as the antivitrectomy is begun. We need to remember that in the presence of a PC tear, the antechamber and the vitreous have direct communication. VSS from a high bottle height gets instant access to the vitreous cavity. The sudden gush of fluid will extend the PC tear even before the vitrectomy has begun. And finally, segmenting the vitreous in two parts by placing the cutter behind the posterior capsular tear helps us to cut the vitreous around and behind the PC tear, and at the same time losing the communication with the prolapsed anterior vitreous. Dealing then with the anterior prolapsed vitreous is not going to enlarge the posterior capsular tear. Thank you. How do we prevent enlargement?
So just a couple of points here. Whenever the vitrector is down inside, we are not going to move around like this. It's going to be very stable. It is going to be just sticking on there. You are not going to move around there. It's going to be very stable there. The only single most important secret is, the pressure difference between the posterior, the chamber which is posterior to the posterior capsule and anterior to the posterior capsule. The pressure differential should not be there at all. So there should be minimal turbulence. If you can play, or if you can understand this part of the fluidics pretty well, then you can minimize the extension of the posterior capsular tear in majority of the situations. So what is a common mistake happens is when you're doing a cortex aspiration or phaco, whatever, the bottlet is usually at 90 centimeters. There is a PC tear. You push in OVD. In the first in panic situation, you don't look at it. Directly go in with the same irrigation pressure, which is 90. Whenever there is a communication between the anterior chamber and the vitreous cavity, initially there is no communication. Now because the anterior is broken, there is a direct communication. The fluid has direct access to go into the deep well, and that's the reason suddenly the chamber deepens and everything goes in. That is the reason why your posterior capsular tear suddenly enlarges. So before even you start doing your vitrectomy, the PC tear would have enlarged. That is one point. Second would be position your vitrectomy cutter appropriately when start doing the cutting. So if you're very careful in the way you position the cutter, then you will take care of, you can prevent the extension of the tear. When do you do, the rhexis? When the vitreous is already there in the anterior chamber, that time it is difficult to do the rhexis, and also not advisable because we can induce traction. So first do a vitrectomy, limited vitrectomy, and then do the rhexis. Thank you.
Dr. Mallikarjun has a question.
That was a nice presentation, but see, still many people, they hesitate to use the triamcinolone.
Okay.
So
yeah, I think that's a very good question.
How much to dilute?
Yeah, I think the 2 or 3 main concerns are, one of the common concerns is incidence of steroid-induced glaucoma. I think we have been using this for many years now. That really has not been a botheration for us. The recommendation is anywhere between 1/4 to 1/10. So one part is triamcinolone, 4 part is BSS, or 10 parts is BSS. If it is too diluted, you can't really see well. But in our experience, we haven't found anything which is contraindicating for the use of this thing, like in the form of a raised pressure, which is not manageable. It has not been. Second concern would be infection, but both of these are, I think, slightly hyped up concerns. If your other parts like sterilization are and all okay, shouldn't be a problem. I think at least, you have to use, I preferably use 2 times. First to identify, and second before closing. It's very much easily possible to miss one vitreous strand somewhere. That's the reason why before ending you can just use it. Apart from identifying vitreous, it has a definite role in minimizing the post-op inflammation.
Continuing the same question, when there is dispersive OVD and injected triamcinolone, will it coat the vitreous?
Yeah, I think that's an excellent question. See, what happens, the classical teaching is whenever we break a posterior capsule, before coming out, you put dispersive OVD. And then after that, you have to identify, you have to put a triamcinolone acetate. So whenever the OVD is there, the staining might not be perfect, but still it is good enough to identify and stain few strains. And there are other indirect evidences like, the splaying up or widening of the posterior capsule. That indicates that, there is a vitreous which is prolapsed. But definitely even in the presence with the OVD itself, when you use a triamcinolone acetate, the staining might not be very good, but still it works. Thank you.
Thank you.
I think we can discuss, write down this. That is standard answer. No, so if you don't have any support, if the rhexis is intact, you can go ahead and put a cell case. There, then you have a choice of putting an iris claw lens or a scleral fixated lens, depending upon your choice. So that would be this thing. So you have to put either of them, depending upon your expertise, skill, and your preference.
I invite the next speaker, Dr. Saurabh Patwardhan. He is from Nandadeep Eye Hospital from Sangli, Meerut. He is an excellent phaco-refractive surgeon. He'll be speaking on anterior vitrectomy through the posterior approach.
Thank you, Dr. Bharti. Thank you, Dr. Deepak, for inviting me for this IC. I am also a retina surgeon. So, pars plana approach actually comes naturally for retina surgeons, but I was surprised that for my phaco cases, I hardly use pars plana anti-vitrectomy approach as a routine. But there are certain situations where it's really
Dr.
useful.
Saurabh Patwardhan from
You can stop.
Nandadeep Eye Hospital.
Okay, so as Dr. Deepak has nicely showed that even approaching the anti-vitrectomy through the limbal route can do most of the things correctly, and so we rarely need to go pars plana anti-vitrectomy otherwise, but there are certain special situations where it may be helpful. Of course, some surgeons advocate it for all anti-vitrectomy cases. So the thought process behind why we need to go through pars plana for doing the anti-vitrectomy is like this. When you go from a posterior approach, it might be a better approach, because what is happening when you are going through the anterior route, you are actually, because ultimately what the vitrectomy probe does is that it pulls the vitreous and cuts. Of course, with higher cut rate and the lower duty cycles, the traction is going on down and down, but still it is little bit pulling out the vitreous. Here you are going through the pars plana route, so it is pulling the vitreous back into the vitreous cavity. Thus, it reduces the chances of extension of the ruptured posterior capsule, which Dr. Deepak was showing how to avoid by going through the anterior route as well. But pars plana anti-vitrectomy, this extension is even less common. So another very good point where it is really useful is when there is already a presence of IOL in the bag. In such cases, what happens then, if there is a vitreous strand coming from behind, going through the anterior route, navigating around the IOL and cutting that vitreous sometimes is an issue. So in such cases, if you go from the pars plana route, you can cut from the source, that from where the vitreous is coming to the anterior chamber. Sometimes these vitreous strands are going right across the IOL, going into the peripheral incisions, which might be easier to cut this way. Another situation where it is useful is when the vitreous prolapse from the site of zonular dialysis, that is from the periphery, or if it is from the peripheral posterior capsular rupture. In such cases, many times approaching that area through the anterior route is little bit difficult. Sometimes in that attempt you may damage the anterior capsule or even more of posterior capsule. So in such cases, when there is a peripheral PC rent or zonular dialysis and there is a vitreous prolapse, you can go through pars plana route and remove the vitreous easier than when you approach through the anterior. Of course, there are certain disadvantages. One thing is that the anterior segment surgeons are not usually well versed while approaching through the pars plana route, but it's not that tough. It's just a inhibition for initial case. But you are closer to the vitreous base, so one problem, if you don't have a good cutter, like I think Dr. Mallikarjun sir showed, if the cutter is jammed and you are going through the pars plana route, there is always a chance that you may create damage or create port side dialysis or breaks, because it's kind of a blind process. So make sure that the cutter is working well. So when you are going through pars plana route and you don't have the adequate expertise, or you don't have the adequate imagination where the zonules are, where the bag ends, sometimes if you go too anteriorly, you may even damage the zonules or bag, or if you are going too posteriorly, you may damage retina. Now, though I have seen surgeons can do pars plana anti-vitrectomy even with topical anesthesia or just subconjunctival anesthesia, but I find that most of the patients are not that comfortable with that. So it's better to give a subtenon peribulbar. Subtenon is the easiest thing to do it on table. Subconjunctival also you can try if patient is comfortable, you can go ahead with that. But what I prefer is doing a posterior subtenon anesthesia. Just open up the inferior nasal conjunctiva. You can infiltrate. If the patient is on topical anesthesia, what you can do is just infiltrate the infranasal part of the conjunctiva with xylocaine. Wait for a minute. It gets anesthetized. You open the space to the tenon, use a blunt cannula like 18 gauge visco cannula, and use 1 to 1.5 cc xylocaine through that infranasal route, and it gives a very good anesthesia to the patient. Patients are very comfortable after that. I will show certain cases where it was useful. So this was a case where there was a PC rent. I am doing here what is called dry aspiration. So I am not using any irrigation and trying to take out the cortex which is remaining. You can see that there is a large peripheral, PC rent, and there was a vitreous prolapse from that side. Now approaching from anterior route sometimes becomes little bit difficult because it's in the far periphery, and invariably you will end up damaging more of posterior capsule. So I will just go back and show how the trocar was inserted. It has to be 3.5 millimeter around from the limbus. You can go 3 millimeter as well because now you have removed the cataract. The direction should be towards the center of the globe. Okay, and most of the times when you are doing this, the eye is little bit of hypotonous because there is already rupture and eye may be hypotonous. So in that case you have to do this jiggly movements. You have to rotate this trocar little bit so you can pierce through this sclera even if there is hypotony. You can see this is a walled trocar cannula. So if you are using it, it is good idea to use a walled cannula rather than non-walled, so you don't get the vitreous incarceration later on. And also it is self-sealing, so there is no egress of fluid or even vitreous incarceration during that. So I was showing the same thing again. Direction little bit oblique first if possible, but if you are not comfortable with that, because for retina surgeon it's usual, for anti-segment surgeon you can go even straight. Try to use the sharp, if possible, new trocar cannula. So this is the wriggling movement which I was showing, which is useful for passing this trocar through the into the pars plana area. Now once that is done, the irrigation is from the anterior root, and the cutter will be used through the pars plana. You can see I have gone in through this pars plana area and I will start the cutting. My cutter is behind the posterior capsule, only in the area where there is a posterior capsular rent. So what happens when you use pars plana anterior vitrectomy? The anterior vitrectomy is very, very quick. It just takes few seconds and the entire vitreous is out. So I think that is a one good point about pars plana anterior vitrectomy, that it's much quicker, because the chances of vitreous getting incarcerated into the incisions, because whenever you use anterior limbal incisions for anterior vitrectomy, invariably there will be vitreous strands which go and get trapped in these incisions. These chances are much less when you go for pars plana anterior vitrectomy. Okay, so this was a case where the anterior capsule was torn and the rent has gone to the posterior side. Now this was another case which one of my fellow was doing, and on table it was realized that there was a zonular dialysis, and so one of my colleague placed the CTR to stabilize the bag. But when he started doing phaco, he realized that there was vitreous prolapse from the area of zonular dialysis. So when there is a vitreous prolapse from the area of zonular dialysis, it becomes little difficult to do phaco, because every time you go in, you will try the phaco probe will catch that vitreous. So he tried to do anterior vitrectomy from the anterior root, and again started doing phaco. But invariably, because when you are doing phaco, you need the anterior chamber to be maintained, so little bit of bottle height is used. But whenever he started doing phaco, there used to be more vitreous prolapse. Okay, so I will just show you what to do in such cases. So the problem is that there is direct communication now, and vitreous is prolapsing from zonular area. So what I did, I removed that iris hooks and just passed through the anterior CCC and held it tight. So what happened, the space between the bag and the sclera is reduced now, and now I can go ahead and complete the phaco. The iris hooks are supporting the bag as well, so there is no chance of bag getting pulled during phacoemulsification. And the fluidics improved, because once the anterior and posterior chamber were separated, because I tucked out the bag, the fluidics improved and I could remove the nucleus quite easily there, and the iris hooks held the bag. Now in such cases, when I placed the IL in the bag, see, there was around 4 to 5 cloacas of maybe 4 cloacas possibly the dialysis. But in this case, what happens, the fluid goes behind, there is still vitreous which is lurking behind the posterior capsule to come out. So the moment you hydrate, you will find that more vitreous will start prolapsing. Now this is another case where the pars plana anterior vitrectomy really helps. Now here what I am showing is not using any trocar cannula system, but simply 23 gauge MVR is used. Again the same 3.5 millimeter behind the limbus. You can clear the conjunctiva a bit and then pass through, so that you can visualize the scleral area where you have entered when you are using the 23 gauge cutter here. So you can see that now the 23 gauge cutter will go behind the bag there. The irrigation is still in the anterior chamber. Now what this does is that it debulks the vitreous behind the bag. So there will not be any more vitreous which will prolapse out when I remove the iris hooks. And it will also remove the fluid which has been misdirected towards the posterior segment. So once I did that, I realized now AC has deepened. There is no, I would say, decentration of the bag. And now I could remove the iris hooks and the IOL remained well stable within the bag without any decentration. So in this situation where there is possibly vitreous which is behind the bag and can come out through the zonular dialysis area, if there is little bit of fluid misdirection which is pushing the IOL up, in these cases also the pars plana antivitrectomy helps. So always after any antivitrectomy case, make sure you put little bit of diluted triamcinolone in the anterior chamber to look for any residual vitreous, sweep under the incisions and check there are no strands there. So these are good habits to have. Those little bit of triamcinolone crystals which are left are very good for reducing the inflammation as well post-operatively. Now this is another situation where pars plana antivitrectomy is useful. This patient was referred to me by one of my colleague, and he suspected that there was a PC rent. So what he did was that he just placed the IOL in the sulcus and then referred it to me, saying that there might be a possible posterior capsular rent, and of course it was there, and there was a lot of residual cortex left behind. So now here also it's a good idea to go from the pars plana route, because I don't want to nudge around the IOL much. I can go around, because if the IOL is well stable into the sulcus, I don't want to rotate and change its position. I can go from the pars plana route. I can remove the whatever vitreous is there, and through the same route I can aspirate out the cortex which is in the bag with much ease. We can also do two pars plana can use two pars plana cannulas as well, so that we can utilize you can reach both sides of the cortex, or it can be done from one side as well. So you can see the IOL is stable and I don't have to go from the anterior route and nudge this is a big PMMA IOL, so it will be always difficult to go around it into the bag and remove the cortex, and I might damage the bag as well in the process. So this is another area where the pars plana antivitrectomy approach can help. So it's always good to know how to do vitrectomy in different ways. So because there will be certain situation where one type of vitrectomy may be better than the other. So these are few situations where I felt that maybe pars plana antivitrectomy has slightly some more advantages as compared to the limbal antivitrectomy. Thank you. So I think we are very efficient in doing antivitrectomy. So we have finished all the lectures beforehand now.
Yeah.
So that fast you should be in doing antivitrectomy and finished. So I think good to have good questions.
Audience questions? Yeah. Yeah.
Audience interaction. Yeah, please. You can always judge intraoperatively. Sorry.
The question is, if you use very low flow rate, is it good enough to aspirate? It can block the tube. That's what his question is. So you start with the low flow rate, you're maintaining the chamber, and you know whether you're cutting or not. If it's not cutting, then you gradually increase. So you start with 12 maybe, then go to 14, then 16, something like that. Sir, your question. Yeah, it is good enough. There's no question about it. Only it's expensive now presently.
Plasma sterilizer.
I think plasma sterilizer. You have, Mallikarjun, you have experience with it?
We don't have.
Yeah, it's good enough. No? It is best. If you are having it, yeah. Yeah, I think it is fine. No problem. No problem with it.
Only thing with the plasma sterilizer is that the instrument should be absolutely dry to have the perfect effect. Because if there is little bit of humidity, it's basically the hydrogen peroxide which is going in. So if there is a humidity, it will not be good enough for the sterilization process. That should be. One more thing about the bottle height, I think Deepak showed very nicely. Those who are using the active fluidic system, this is what I found out. In active fluidics, what happens, even if you have kept the IOP little on lower side, say 30 or 40, when there is a PC rupture and you go in with the irrigation, the machine detects that IOP is too low and it will, jet the fluid suddenly. Okay, unlike the gravity system where if you have lower bottle height, it will still, go with lower flow. With active fluidics, that is one issue because it will be pressing the bag and going in.
So in active fluidics, I think you have to go down to the lowest
20,
possible
yes.
thing.
So
20, that is what
idea
is possible.
to go to 20, not
if you're
30
using
or
active.
40. So if you are gravity like you showed, I think you reduce to 60 or something like
No,
that.
it is the 28 centimeters. 28 centimeters is
so
equal
lowest.
to 20 only.
Okay,
It
so
starts
same
with that.
thing in active fluidics also you have to
go to the
20.
lowest. So any other question from the audience, please?
If there is big rent and we put transnilo, sometimes it drops down
Yeah.
and affects the glow. So how far we can go to aspirate?
No, you're not going to do anything. Forget about that. Whatever has gone beyond. Whatever is near the level of the PC, that is what you're going to aspirate. See, the vitreous does have some role. You're not here to remove the entire vitreous. Forget about whatever has dropped in. No problem at all. Monitor the intraocular pressure post-operative. That's all.
Yeah, but
We are not going hunting in. I think what she's meaning.
But that affects the glow and becomes difficult to.
yeah, so that's why I think as she showed in it has to be diluted triamcinolone. So if you don't dilute, then there is a chance of over injection. But if you dilute it, because you cannot push more than 0.1 or 0.2 cc. If you're diluted, it will never be over injection.
The quantity you inject is also very important. 0.1 cc should be just good enough to identify the vitreous strands.
For the sterilization of the cutter, you use 3 flushes with the BSS.
Yes,
2 flushes with the air, and then dry with the
air compressor.
So Dr. Mallikarjun is from Sankara group of hospitals. They have charity as well as paid being. Any questions about the standalone vitrectomy machines you would be able to answer and address?
I have one question.
Yeah.
You must be having access to both the vitrectomy inbuilt and efficiency wise. Do you find any difference between this and that? In the way the standalone is the last resort. If you don't have a phaco machine, then you have to resort to that. Or sometimes the electrical cutters which you are having with your basic machine might not be efficient enough or difficult to have. In those situations, that's a good option. So my question is how efficient it is compared to your.
See, the only difference is what the cutting rate we cannot go beyond
960. And what I have found is the connection issues are a problem with those. Sometimes suddenly in the middle of a crisis situation, there will be loose connection. You don't know it's not aspirating. That is one thing which you have to be.
So the one I'm using is the Oscar Vision. It has 3000 cut rate and good vacuum, and it has inbuilt compressor as I was saying earlier. So the advantage that is very mobile, So if you have 7-8 tables and rent happening everywhere, so you can just move around the anti-vitrectomy. And good thing is that these usually it takes the mid-lapse cutters or third-party cutters, which I feel are more they have more longevity than the companies which the cutters they give. That's my experience. So
Saurabh, you have some 6 fellows doing PC tears in the machine.
Taking care of the cutter is very important because if you don't have a posterior segment setup, so we'll have only 1 or 2 cutters.
I think the one message we've done to go when people from this course is you cannot start a cataract surgery without having a functioning anterior vitrectomy unit and a sterile cutter at your disposal, because you never know when things can go wrong. So it's like you're driving a car, going on a long distance journey without having a stepney ready. So you never know what things. So you have to have some sort of a vitrectomy unit ready always. I think because the outcomes are such that it's almost indistinguishable from a routine one when you manage it very efficiently. So probably the most important equipment in your operation theater after a good sterilizer is having a good functioning vitrectomy unit for a cataract surgeon, because obviously you can remove cataract without a phaco unit as well, but if to manage a complication you should have a good vitrectomy machine. That's what.
And this is one doubt to Dr. Saurabh.
I'm not sure. I think
it cost to be specified, it cost less than 2 lakhs.
The Oscar,
No,
you're sure about Oscar?
Yeah, Oscar,
Oscar is around 2.75 to 3. Oscar, I will find out and give it to you. I will find it.
He must be there in the stall, right? Here,
It must be, yeah.
He must be.
Oscar Vision is there.
Pardon me, sir. I didn't get your question. Huh. No, that is not advisable. Not at all advisable.
The problem with formalin chamber sterilization is that there are no standards which are there. So when do you say that it has sterilized the equipment? There are no indicators or nothing to decide that process has been complete. And of course now it's not it has a
No, it is
carcinogenic
just no.
effect and all
It
that.
is not at all recommendable.
The chances of TAS are also
Because
high.
there is no end point to it. How much you have to place, so how much quantity it is to be placed, how many days. No, sir. I think now don't compromise on the sterilization aspect, because these cases are vulnerable for infection because already there is a complication. So always try to have the most sterile equipment at your disposal at this
And
stage.
almost all cities have access to ETO machines somewhere. Many of the you may not be ophthalmologists, but even general surgeons are using ETO. So you can get it ETO'd and keep it, because ETO'd material can be used up to 6 months or 1 year also. So you can keep the ETO'd cutters extra. That works.
For autoclavable cutters, how many reuses are allowed for these autoclavable cutters?
reusable.
Okay.
How many cycles? How many times?
If you maintain it nicely, 2-3 times,
So you can
maximum
use
2-3.
2 to 3 times.
2-3 times you can use. So one doubt to Dr. Saurabh.
You can do post.
You can do with vitrectomy cutter, no problem. But definitely the strength will not be as good as your forceps. But there is some indications where vitrectomy cutter is the best choice. Suppose you are dealing with a bag which is very loose, like it has zonules are very loose, and when you try to tear with the forceps, the entire bag will be moving. Second situation, you'll be having a calcific plaque, which is very difficult to grasp and tear. These are few of the situations where you can definitely use a vitrectomy cutter to do it.
So I think Dr. Saurabh made a point. If ophthalmologists don't have ETO, urologists, persons who do laparoscopic surgery, those people will be having ETO. So you can use the services of those hospitals and get your ETO done.
Yeah, I think, but in our the way the area we practice, ours is very small town. The urologist surgeons send it to us for getting ETO'd. So they don't have ETO machine. So actually, the surgical asepsis part, only the ophthalmologists are the highest who really take care of the aseptic part. So don't expect a urologist, surgeons, other people to invest on that. So better to you yourself buy an ETO machine. It is really worth it. So or a plasma sterilizer, whatever. So it is really worth it, because I don't believe the general surgeons or other people are so much bothered about us. They send it to us only. We only do it and send it. I was a smaller center, I'm telling you.
Once sterilized in the plasma or ETO, for how many days it is safe to use that?
So 6 months is the general rule, but actually the rule is that unless there is a physical breach of the packet, it's sterile. It can be sterile for years, but for general purpose we can keep 6 months or 1 year. So that's what when we have NABH validation, generally they say that you keep it for 6 months or 1 year. But technically, as even the IOS, they come sterile or something, they have some 3 years, 5 years, something like that. And it's also for general purpose. It's not that they become unsterile suddenly after 5 years, unless there is physical breach, because how can an organism enter inside if there is no physical breach?
So it depends on how we store also,
Yes.
how our OT staff maintains the storage
maintain it.
area.
Yeah, how they
So
store.
the physical breach or perforation on the external packing can occur anytime, a small while transferring also. I personally in our center we don't keep it beyond 1 month, sir. If it is ETO or no, maintain it for 1 month only.
I think I showed in the our MOS webinar. We do double packing of all ETO. So we have one wrap, and over that we have one more wrap. So even if the external is damaged sometime, we check for the internal and it's safe. So that helps in longevity, and we are not worried about if both the wraps are damaged, then it's an unfortunate situation. But generally, it doesn't happen.
From where do you get the air compressors?
It's in general, any general electric store you get the air compressors. But use the it also comes with the filter, so use with filters.
Microcore filter.
Microcore.
See, for the past plana vitrectomy, my experience I am telling, when I started doing, we have our post segment surgeon also. So when you ask for the trocar, they give usually used one. So it was very difficult for me to put inside one thing, and also it will be hypotenuse eye. So any tips?
Yeah, so under the microscope, look at the tip first. If it is bent somewhere, sometimes the tip is bent, you can see it's blunt, so don't use that. And another way to do it is, if you have 23 gauge MVR, which is new, you just make the incision and then you can put the trocar cannula through that. So even if you have a little bit of blunt trocar cannula, because it's costly, because MVR blade is cheap, so you can make a entry and then put the trocar cannula through that.
And you nicely showed that when
MVR blade instead of trocar cannula, what are the disadvantages of using an
Only MVR blade, and just so see, earlier when we started vitrectomy, it was 20 gauge vitrectomy and we didn't have a trocar cannula system. One of the, I would say, common complication was port side dialysis and port side breaks. Once we started doing trocar cannula system, it suddenly vanished. So I'm sure that use of cannula will prevent the vitreous base incarceration and damage, but it's not mandatory because you are using it for very short time. If you are sure that the incision is good, the cutters are good, they are not going to get trapped the vitreous, you can do it without trocar cannula also. But if you have trocar cannula, I think it will be better, safer.
And do you want to suture if you have just used MVR blade?
No, it's for up
Because
to 23
trocar
gauge.
cannulas are all self-sealing, right?
Yeah. So if you are using just 23 gauge MVR entry, it doesn't require
suturing. Yeah.
So, but whenever I use, I don't. When I'm using MVR blade, the thing is you have to go in straight and come out. You don't have a valvular action. Now, if you're an anterior segment surgeon and you don't know this way of creating the valve which is self-sealing, I do a conjunctival peritomy. I mark my 3 millimeter with the caliper with the trocar with the MVR blade. You just go directly pointing towards the center of the vitreous and coming back. And then when you're introducing the cutter, there's no cutting until you're going and seeing it. So you're not dragging the vitreous along there. You're just pushing inside and then cut. And extremely important, as Saurav was telling, incarceration of the vitreous in the wound. So keeping that area clear, that is what is very important. When you're coming out, you should be ensuring that that part is totally clear. And because the eye would be hypotenuse and I don't have a sutureless valve incision there, I usually suture with a 80 vicryl and of the sclerotomy port, and then also suture the conjunctiva over it. So if you don't have access to that and you are in a position, you are in a situation where you want to use a pars plana, this option is also okay. But that's what, don't start cutting from the without seeing anything, just like that.
Dr. Saurabh nicely showed in the video, I think, while doing a side port, we hold the conjunctiva opposite side. So because it is not a hypotenuse. When the eye is hypotenuse, when you are entering the trocar, you have to hold the conjunctiva near to the trocar and pull towards the trocar. Then it would make it easy. So because only
I think in the West. They believe the only way to do anterior vitrectomy is through the pars plana approach. Now, for the last 2-3 years, if you attend any international meetings, they're literally told that the only way to do anterior vitrectomy is through pars plana. It's almost like become a taboo to go through through the limbal route. It has got its own pros and cons. The cons are not because here we rarely do it under an IV sedation or a general anesthesia. Their anesthetist is already always there to take care of it. Patient is uncomfortable when you go through a pars plana. The surgery becomes a little bit prolonged. So I think anterolimbal route is safe enough and does almost the same job as your pars plana if you're very careful in maintaining the fluidics. Yeah, but if you attend any of the international meetings, there is nothing like an anterolimbal route. There is only talking about the pars plana approach now presently.
So I think, as I told, that posterior subtenon anesthesia has to be given.
Yeah, you have to
for
augment.
the comfort of the patient.
Even for your anterior limbal also, because it's going to enhance the longer the procedure, the patient becomes uncomfortable.
Your last case, I think, Dr. Saurabh, the entire cortex and everything was just within the bag. You made a pars plana entry. How are you going to be so sure that you're not just going to tear away the posterior capsule and cause a big tear?
So the surgeon had already placed the IL in the sulcus.
Okay.
So and he told me that there is definitely a big central rent, and he pushed the visco basically and placed the IL and closed the eye and sent the patient to me. So he was sure that vitreous is there behind the IOL. So there was already a range. So I went through that area only and removed. And here anterior capsule was anterior CCC was intact. So I was not really worried about sparing the posterior capsule as such.
Pardon me, sir?
What position to enter from pars plana?
Pars plana. Okay.
Pars plana. So it depends on your dominant hand. So if you are right-handed surgeon, for the right eye, you go from superior-temporal route. And of course, if there is a peripheral, dialysis, and you want to approach that area, so find out which is the best way to approach that area. So you can change the position accordingly. Superior-temporal is because easier for you to make the insertion.
Yes, sir.
Center of the globe. Always center of the globe.
No.
Yeah. Just like intravitreal injection, you must have given intravitreal in the same way. You have to.
Is there any chances of this biopsy which is cleared after vitrectomy, the satellite microphone?
There is.
It will there, but it's not going to cause any problem. It will be there.
Don't worry, it will take care of
I had
CME.
Yeah. No, I had like one of my fellows. He did this mistake of not diluting the triamcinolone, and there was little bit of air in that 1 cc syringe. When there is a air trapped in any syringe, when you press, the fluid will pass suddenly inside. So that one thing to avoid. And he pressed it, and that just triamcinolone jettisoned into, and that patient had steroid induced glaucoma, and the notes written were just PC rent, anti-vitrectomy done, and IL was in the sulcus, and we were confused why there is such a high IOP. We thought that if there is a block, pupillary block, and then we saw the video and we realized that he had put so much of triamcinolone. So we went ahead with pars plana vitrectomy, and next day patient was like absolutely clear eye. So that has to be avoided definitely, because you have already done a complication. You don't want a complication of a complication.
Yes, sir. Thank you. Okay, I think the pneumatic is the best. There is no question about it. Highest whatever is your machine can afford, that you have to set it. Minimum, minimum is that reticare with Dr. Heralgi showed.
We are minimum maximum I can go up to 900. So that's what
it is.
So you go, sir. If you go for higher cut rate, it will be more easy.
So nowadays, cut rate is very useful. But in case you have a machine with lower cut rate, just use lower vacuum, because then the duty cycle will be less. So earlier we used to do pars plana vitrectomy with 200, 300 cut rates also. So it's not like you are going to have a lot of complication with lower cut rate, but the traction on the vitreous will be far less. So with far less with higher cut rates. But I think good working cutter is more important than the cut rate. If it is a jammed cutter, you are just pulling the vitreous all around. So that sign, I think you showed how to check for that. And even during surgery, because see, we are going to reuse these cutters. So if it is not working, you have to go in. Once you find that it's not cutting, don't try to keep on, pulling, because what happens is that vitreous strands go in and it just keep on pulling on the vitreous rather than cutting. So you have to immediately stop at that point. Stop the cutting. You can see the vitreous is cleared, so you can stop at that point. No. You have to stop and then withdraw.
If you stop, if there is some pain in the mouth,
So that's what. That's why you have to visualize it. You have to complete all the cutting, then stop the cutting. Don't give any vacuum, and then come out.
And then in the wound again, you have to just
Check for it, then
for
this
vitreous,
thing,
and then in
incursion.
the wound you have to use the cutter again. At the
So
wound.
it's always little bit blind procedure because it's always little bit
Always,
blind.
it's
Yes.
always going to be.
So it's safer to keep the cutting on and then withdraw that vitrectomy.
In that case, what happens sometimes if you are you have to look at the port also where it is. If you go very close to the where there are other structures like ciliary body and vitreous base there, and if unfortunately you damage there, sometimes there can be bleed or dialysis in that area. So best to see that it stops cutting, there is no vacuum, so it's like a idle, just like a needle inside, and you can remove. If it is not active, then
Area, if there's some nothing here, again,
Externally also you can do the cutting. Near the wound area.
yeah, externally you can also do the cutting.
Cutter should be parallel and then posterior.
Cutter position.
Again, whenever you are entering center of the globe, and then you go anteriorly. Always, any time you go.
It starts getting constricted when doing.
Yeah, so use the iris retractors or pupil expanders. This is something which I tell to all my fellows, because invariably, when I ask my fellow why this complication happened, the story starts with, sir, the pupil became smaller and then I did this complication. So that should not be any excuse for we have pupil expanders like iris retractors. Very easily you can put. Good visibility means you can have a good outcome and good surgery can be done. So many times what happens, we feel that it will take long time to put iris hooks and I will just finish off the surgery. Many times you take longer time because you have not used iris hooks, because you struggle with the steps. Best is to just retract the iris, complete the surgery, and it will reduce the chance of complications.
In case of IFIS, is there any special precaution which we should take?
Like if it is a severe IFIS where the floppy iris is there, just put a pupil expansion ring, and then it's just like a routine case. So the principle behind floppy iris is that avoid any fluid passing through any of the incisions. So I typically use, I call phaco entry and phaco withdrawal ritual. I stop the irrigation, I enter the probe, then I start the irrigation. Again, while coming out, stop the irrigation, let the eye be little hypotonous, then take out the instruments. There will not be iris prolapse, because iris is fluid basically. It will go wherever the fluid is passing, like that. Yeah, so whenever with PC rent it's not an issue, but whenever there is a zonular dialysis, you have to be really careful. So you have to visualize where the tip is. The vitrectomy probe in 3 dimension, you have to see that it's deeper than that. There is no need to go closer, because see, the cutter is going to pull the vitreous back. So you don't go near the back, just go behind, start cutting. The vitreous will get pulled back. Immediately, the AC deepens. So it's better to keep the vitrectomy probe little back.
And sometimes when you're not sure about the position, sometimes it happens. How deep are you? How away from you? Start with the port facing sideways rather than front. Okay. So sometimes assessment may be wrong. You think you're deep enough, but you're enough. Go and catch the posterior capsule there. Start with the sideways or posteriorly, and then you get an idea. Then last maybe you can try once, or go still behind and then turn the port upside down. So always go in with the port sideways, even with pass plan. That is one way of protecting the thing, I think.
Yeah, I think the time is. So basically in pass plan anti-vitrectomy, you don't need to actually cut the vitreous which is coming anteriorly. You cut it behind. With the irrigation, the vitreous goes back like that. So you don't have to come anteriorly. It just gets pushed back.
So we come to the end of the session. If you have questions, any of the delegates can personally meet the co-instructors. Thank you for participating in this IC. Thank you all.